be too discouraged. Well, there are like 200 slides for this chapter, and I that's going to really upset some of you, right? And I don't want that to. Natalie, you still look upset about this. You still look like 200 slides. How am I going to handle that? The slides again for this book. The slides are really, I mean, they basically just rewrote the book for you in the slides. So there's going to be a lot that we're going to kind of talk about, and then it's just going to be on the slide, and I can go, okay, we don't really have to spend time on that, right? So we can move on. Emily, this is the exact opposite of how I have slides for aggression, where I'll have maybe one slide, and we'll talk about it for 2 hours.
And it's like rat pee and then nothing else.
Montana, you remember that?
That's exactly how it went.
Yeah. For those of you who weren't, smart enough to take that class, you missed out because it was thrilling. We didn't talk about Hamstar this year, though. Remember the hamster we talked about that was the racing hamster? Yeah, we talked. Yeah, it was exciting. All right, so principles of psychopharmacology. We want to spend some time talking about various sort of foundational things, right? So we want to talk about what is pharmacology. We want to talk about pharmacokinetics, right? This is going to apply to every kind of substance you'll put in your body, right? That we would think about. How does it get in? How does it move around? How do you destroy that? And what happens next, right? So those are the things that we want to think about. We want to think about therapeutic aspects of drugs. We'll think about non-therapeutic aspects of drugs. We'll talk about some of the effects of chronic drug use, right? And when I say chronic drug use, I don't necessarily mean drug abuse, right? I mean, how many of you know someone who's been on cholesterol medication for 2 decades, right? Like everybody, right? That's chronic drug use, right? My guess is, all of you at some point in your life have used drugs. That's just going to go out on a limb there. I can see a number of you are using drugs now because you have some caffeinated beverage, for example, right? I mean, that's in the drug category, right? So that's kind of an important point we want to think about. Anything that you put in your body that comes from outside your body, we're going to call that a drug, right? Any kind of substance that comes in and changes the way your body works in some way, that's a drug, right? For our purposes, we're really interested in those substances you put in your body that change the way your brain works, right? We're not so interested in changing the way your liver or your heart functions, right? So we're not going to really talk about cholesterol medication, except as maybe an example here and there. We're really interested in that other sort of aspect, right? Eventually, we'll talk a little bit about some genetics and personalized medicine, which is going to be pretty exciting, right? So when we think about pharmacology, what really is that? We're just thinking about drug action and how that affects a living organism, right? I think it's important they put living in there, just in case you thought we were going to give drugs to dead animals or something and see what happens. Nothing would happen. That's exactly what happens. So prior to the 20th century, and I'm going to assume none of you have lived in any centuries other than the 20th and 21st. Prior to and some of you haven't even lived in the 20th, have you?
I was born in 98.
Okay, so but some of you may not have lived in another century. How about that? Anybody born in 2000 or later? You don't have to answer it. Right, there you go. So you've not lived in another century. You didn't even live in the 20th century. Boy, it was crazy back then. It really was. Prior to that time, most drugs were just naturally occurring substances, right, that came from plants. And we still use a lot of herbal medicines today, right? Other cultures may rely on those more heavily than we do here sort of in the Western world, so to speak. They may be more applied to different sort of ailments, right, and different things. That's not to say that on some level I'm going to say they're not as effective. And the reason I'm going to say they're not as effective is there wasn't a biochemist in there like bending molecules to make them more effective. That's just how they naturally occurred, but that doesn't necessarily mean that they're ineffective, right? And so natural medicines is perfectly fine, these herbal medications. In fact, most of the top medications that are prescribed even today are based on some sort of natural herbal plant-based medication, right? Really kind of interesting. There was a few years ago they recovered a Neanderthal skull, right? So this is sort of like ancient human, and the guy had an abscess in his jaw, right on his tooth. I don't know if any of you have ever had a toothache. You've had some sort of tooth problem, causes some problems. The interesting thing is he had tucked in his jaw a piece of willow bark. What can you extract from willow bark is some of the key elements to make pain relievers, to make like acetaminophen, right? So it was really interesting that, so he was using a drug, I mean, it was just like willow bark, right? And so as a species, even before we were a species, this species, we've been using drugs, right? We've been using these external substances to change the way our body works, right? And I think once we get into talking about who's got the like the hallucinogens, of course that can change, right? Once you get into some of those the psychomotor stimulants, you know, you talk about like you know, Colombian miners and their you know, like the coca leaves, that they work faster, right? When they have those. Tobacco, for example, is a, you know, a drug that's been used for probably millennia, you know. So these are things that to think about, right? What we've done since the 20th century, during the 20th century, and since then, is as we've made advances in chemistry and biology, and as our technology has developed, we've been able to extract those key elements from something like willow bark. We've been able to process that and produce that on a mass level. We've been able to tweak those molecules so they work a bit better. Let me rephrase that. So they work a bit more powerfully or a bit longer, right? And so in some sense, we're going to think about that as better, right? If you pop a couple of Tylenols, that's probably better than like chewing on a piece of willow bark, right? It's probably going to be more effective to deal with your pain. If you've taken a molecule and you've tweaked it in such a way that now it gives you such a faster, more powerful response to something like alleviating pain, you've not only like helped folks who are dealing with pain issues, you may have also inadvertently created a situation where it becomes more, it increases the likelihood that it's going to be abused, right? Because you get those sort of euphoric effects more. So when I say better, I didn't necessarily mean globally better, right? It's just more effective at dealing with that issue. So there you go. So that's a thing to think about. For us, we're thinking about neuropharmacology or psychopharmacology. There is a difference. I don't really think you're going to think much about the difference. One of those is really focused on how does your nervous system change, right? And the other one is sort of focused on how do the outputs of that nervous system change, right? Like your mood, your thinking, your behavior, okay? And we can actually learn a lot by giving people drugs, by giving animals drugs. We can learn a lot about how your nervous system functions normally, and we can sort of disrupt that. All right, let's talk about a few other sort of terms that we're going to want to use throughout the semester to kind of get you oriented to them. Some of them are quite simple. I think drug action is a pretty simple term. It's just the action of the drug, right? I mean, it's right. I know it's right there in the title. But what we're really thinking about is, for our purposes, we want to think about those molecular changes when it binds to that target site, right? Really, that's the drug action, right? That's different than the drug effect. The drug effect is how does that change that physiological or psychological function, right? There's a difference there.
Is drug action, like we're talking about here, any different than method of action, or are those kind of interchangeable synonyms?
I would think they would probably be similar. All we're thinking about with drug action is the drug binding to the receptor and starting that business. The output of that business is the effect, right? So that's where we're thinking about drug effect versus action. Does that make sense? What is important is the site of the action might be different than the site of the effect, right? It may have some action in your brain. If you think about caffeine, for example, right? Caffeine has some action in your brain, but what's the effect? I mean, you could think of elevated heart rate, right? So it's kind of think about things working in different places. All right. For a lot of drugs, we're going to think about therapeutic effects, right? This is when we're shooting for some desired physical or behavioral change. This definition, I think, is a little troublesome, right? And I think our definition of, this is what I want you guys to think about some, is right, our definition of therapeutic versus side effects might change over time, right? So if you think about what is the desired effect of taking Tylenol, it's reduction of pain, right? So it's not a big deal. What's the desired effect of taking alcohol? Is that a therapeutic effect? I mean, you wouldn't really think about it in terms of a therapeutic effect, but at the same time, by this very strict definition, well, that was the desired effect, right? Why did you ingest that alcohol? To change your mood in some way, right? So you can have some different subjective experience. So I want you to just kind of keep that in mind as we think about that. If I talk about therapeutic effects, I'm typically talking about this is a drug that was, we'll typically apply this to things like antidepressants. What are the therapeutic effects of an antidepressant? Obviously, it's to reduce depression. What's a side effect? That's maybe a little easier to describe. For an antidepressant, side effect is going to be sleepiness, right? It's kind of like the top of the list. Sleepy. I always love the side effects of antidepressants: sleepiness, weight gain, and sexual dysfunction. If you weren't depressed before you had those, I think that those three things are, you're just going to want to sit on your couch. You're going to gain weight, and well, you got the third one there. You're not going to be doing either. So you got to be careful, Brooke.
Can the side effects also be positive but still not the intended effect?
Oh, most certainly, right? Yeah, most certainly they can. And this is quite honest. Honestly, this is how they come up with certain, like, when they give one of these drugs for like 55 different problems, this is why. So some of the, I can't remember the drug name now. It's a whole class about drug names, so I should probably remember that. What's the drug that they give people so that they'll stop smoking? Yeah, so that really wasn't like initially a let's get people to quit smoking. It was to treat something else, and then they noticed, you know what? These people aren't smoking now. Huh, I bet we can give it to people for that too. So there is a side effect that was definitely positive, right? I mean, I think most people would argue discontinuing tobacco use is a positive thing, especially in that inhaled form. Carries a lot of side effects itself, right? Like lung cancer, that's at the top of the list. You guys were curious what that was. Put it on the label. So yeah, so side effects are not necessarily negative. We typically are concerned about the negative side effects. Nobody's really concerned about the positive side effects, right? They don't tell you, like, you can take this medication and it's going to make your hair shinier. Nobody's going to get worried about that, right? That's going to be, oh, that's great, like my hair's shiny now. I don't have to use as much conditioner. You're worried about the other things, right? Like your toenails may fall off. I don't know. I'm just like making up random bad things that can happen to you, right? So yeah. So side effects can definitely be positive. Yeah. All right. So here's like a definition that uses the word specific, but at the same time is sort of vague. Why drugs have their specific actions and their specific effects is based on how they actually interact with those targets, whatever that is. The shape of the molecule, and I'm not going to expect you to learn like molecule shapes, right? I'm not going to ask you to do that. What I will ask you to do is think about those shapes of drugs, right? And you make any shape you want. Okay, Rebecca, you could, if I talk about a particular antidepressant, and I say that's works on the serotonin system, just know that it's probably shaped like serotonin, right? And if you think serotonin is shaped like a triangle, that's perfectly fine, right? Just think about the drug shaped as a triangle with a little flag on it, right? And there you go. So shape is what's important, right? these receptors have a specific, these target sites have a specific sort of shape, and you have to put a thing in there that fits that, right? If the molecule is close enough, it'll still bind. And in fact, you might have the natural molecule that you're producing might just be close enough, and that synthetic or semi-synthetic molecule that a biochemist made or something might actually fit better, right? And so a great example of this is things that work on like your mu opioid system, right? How many of you have ever heard of opioids? Oh, yeah, it's a rhetorical question, but thanks for answering anyway. So if you think about opioids, why do opioids work? Well, they work because there's a receptor to which they can bind, right? In your body. Why do you have a receptor to which they can bind? Because you're creating something in your body very similar to Oxycontin, right? It's got a similar shape. That's why Oxycontin works when you take it. It binds to that same location, right? And in fact, it binds a whole lot better. It binds more strongly, and it causes a bigger effect than the sort of natural or endogenous opioids that you're creating yourself, right? So there you go. Usually things that are not in your body are more powerful than the things you're making in your body, right? If what you were making was good enough, why would you need to take something from outside your body, right? If the endorphins you were making were good enough to deal with that shattered leg you have from a car accident, you're not gonna need to take Oxycontin, right? It's just not gonna happen. Okay. Your natural opioids are probably not going to help you a whole lot with that shattered leg, right? So that's why you take some other pain relievers. All right. Questions about that? Okay. So that's about the drug itself. There are things that are not about the drug that also sort of have some effect on drugs, have an effect on the effect of the drug. And that's going to be things about you, right? How many of you, you don't really have to answer this, but we can think about, some rather innocuous examples. How many of you have taken the same drug as someone else and had a different response to that? And same drug, it can be an antidepressant, it could be something for cholesterol, it could be caffeine. How many of you know someone who's sensitive to caffeine? There are a number of people who are, right? It happens. But there are some people who you see, like drinking 50 Red Bulls a day, and they like still fall asleep in the middle of class, right? There are different things about you that maybe make this drug work differently in, once you get it. Some of that is going to be even related to things like your mood, your expectations, your perceptions and attitudes. Hopefully some of you are going to talk to us a lot about LSD. That's going to be a great time. If you don't, we'll talk to you about LSD for a while. That's going to be great. Your expectations coming into that experience have a major influence and effect on what happens, right, and what that experience is to you. And I think Montana will have them listen to that radio lab.
That's one I love to talk about.
Yeah. So let's plan on playing some good. It's not really a podcast, I guess. I'm sure it is. I mean,
it's like a 10 or 15 minute little podcast.
Yeah. It's a good. Yeah, it's a good story. It's a good story. We should talk about the Russian torpedo too. When can we talk about that? You guys like Russian torpedoes? Brief preview. It's an anti-drug pill they put in your butt in Russia to make you stop drinking, right? So it's like it's a true story. I know, right? You're thinking, like, how does that work? You'll find out. We'll talk about that when we talk about alcohol use, right? Who's got the alcohol chapter? Oh wow, you guys have, and you have the hallucinogens as well, right? So yeah,
We got some fun.
double whammy there. Yeah, you're gonna have some great stuff. Yeah, the Russian torpedo. You should. So I don't know what else might come up when you search Russian torpedo, but maybe when you go home, try Try that. It'd be it's from the same group, the same. What is the name of that podcast?
Radiolab, right?
Yeah, Radiolab. Yeah, so it's from the same guys at Radiolab. I don't know if you guys listen to that. You should. It's it's really pretty fascinating. This guy went to Russia just to like kind of learn about this Russian torpedo, and he walks you through like going into this clinic to get the torpedo implanted, and it's pretty interesting. All right. How many of you have heard of the placebo effect? That's something we should talk about, right? So placebo effect is like a real thing. I know most people think that's like a fake thing. It's a real thing, though, right? It can have therapeutic and side effects, which is really kind of interesting. And it's usually conducted with some kind of inert compound, right? Something that's not actually going to cause those changes that you would anticipate, right, internally. We usually think of this as like a sugar pill, right? You know, that's what most people, you take a pill with some sugar in it, and it's not really going to do anything to you, right? So you don't have to worry about it. But what's interesting is that like believing that a drug can work can actually get you some benefit from that, right? Which is really, really fascinating. This is not, I want to be clear, this is not simply you just thinking things are better. Like if there are objective measures of your symptoms, there's actual improvement, right? So there's actual improvement. So it's really kind of fascinating how this works, right? So it's really kind of fascinating. Why could this be the case? I mean, there's Pavlovian conditioning. Having someone in a lab coat give you something is a great way to make it more effective, right? Right? Just wearing a lab coat. He gives you a Russian torpedo, and all of a sudden things are better, right? That ritual, right? That experience, and that's something we'll talk about more. Is the sort of ritual of taking drugs, and you do think about with illicit drugs there being a ritual with that, but you don't always think about the ritual associated. With taking Lipitor or something, right? Right, but there is some, right? Who did you get that from? You got that from a guy with a stethoscope and a pair of glasses, and he was probably bald, had on a pair of loafers and a lab coat, right? And had his name stitched on it. You're going to believe whatever that person gives you is going to be effective, right? And so there's some ritual there. You've got a bottle, and you take that out, and you take it at a certain time of the day, and there's something to that, right? And so that can actually have some interesting effects. One of my favorite examples of the placebo effect was a number of years ago. They gave two groups of individuals a placebo, and they told them it was a pain reliever. They told one group that the pain reliever was on sale this week, and so it was less expensive. And so they gave them the placebo, and they reported their alleviation of symptoms, right? And so there was some alleviation because they were taking a pain reliever, right? There was another group of individuals received the same sugar pill, and they were told this is a very expensive pain reliever, and it's costing us a lot to get this for you. They also reported alleviation of symptoms. Their alleviation was greater. Like they thought the drug was more effective because it was more expensive. I know, right? It's fascinating, right? I mean, it's really fascinating.
It's true. At the pharmacy, we'll get people that will refuse to get like store brand stuff, and I'm like, it really works the same, and they're like, nope, I have to have Aleve, and I'm like, okay, here's the Aleve, like, have at it, it's fine, it's $10 a bottle, and the store brand's like $4 a bottle, but if you want to spend your pension on $10 bottles of Aleve, be my guest.
But see, now they're not wasting all of their money because they are getting some benefits.
They're not. I just think it's crazy because they are
weird, isn't it?
Equivalent drugs, or they wouldn't be able to market them as equivalent, and they just don't understand that, or they just don't care. I guess it's crazy. You
could have them subscribe to my YouTube channel.
Most of these people are like really old. I don't know if they really know how to operate YouTube.
Hey,
so
they don't have much time left. They're just burning their money. They don't want to leave it to their kids. Let them spend it on the expensive drugs. I don't know, right? Or are they like your grandparents and you're like, hey, I want that $8 difference?
No, they're not my grandparents.
Okay.
My grandparents understand the difference. My grandma used to work in a hospital. So she's pretty savvy.
You're good there. Yeah. You never know, right? So on some level, I think drugs cost a lot of money, right? You probably know this. They're expensive, far more expensive than they probably need to be. But then it kind of makes you wonder, like, well, maybe they do need to be more expensive so people will think they work better. I don't know, right? So that's what I would use as a justification for like jacking up the price of my pharmaceuticals. I'm like, well, because it's more expensive, and here's the study, people will think it works more and they'll get better benefit from it.
That's what they do with these new brand name ones. There's a couple of atypical antipsychotics. It's Rexulti and Abilify.
Yep.
They're both about $1,000 a bottle, and
Yep.
people like want it, and I'm like, you're lucky you have really good insurance because this is literally $1,000 a bottle, and they're like, it works better than anything I've ever tried, and I'm like, I don't know about that. I'm not positive about that. But every time one comes out, you'll see the same patients like switch the drug that they're on to the new one that came out that's a brand name.
Yeah.
Just got out of the clinical trials, and I'm like, did your doctor just let you do this?
They do.
They do. Like I
They
see
do.
$3,000 prescriptions, and I'm like,
Yeah.
what is wrong with you all?
It's expensive, but there you go, right? So how many of you took this class so that you could make drugs and make a lot of money? Nobody? Yeah, there you go, right? I mean, that's what you should do. Right? So there you go. So there's some reasons for the placebo effect. Genetic variants. We'll talk a little bit about genetics, and in particular in a few moments, we're going to talk about enzymes that break down drugs and why some people are better or worse at breaking down drugs and metabolizing those, which is going to be kind of thrilling. Anybody had a gene panel before for specifically for like drug action? Anybody's had one of those? They're not that expensive. I mean, I say they're not that expensive. They're like a few $100s. But that's cheaper than like continuing to take drugs that aren't going to work for you, right? So for example, they do this a lot for folks who, if you've tried a number of antidepressants and they don't seem to be working for you, they want to, because most antidepressants work on your serotonin transporter, right? Because they'll block that reuptake process. We'll talk a lot about that later. The problem is some individuals don't have really good serotonin transporters to start with, and if you're blocking something that didn't work anyway, you're not going to see a difference, right? So if you think like your car is too heavy and that's why it doesn't get good gas mileage, but when you look at your car and you realize it's a Yaris, you realize it's not the weight of the car that's giving you bad gas mileage. I mean, you're getting pretty good gas mileage out of that car, right? So like trying to get rid of weight is not going to help, right? Because you're already pretty lean as it is, right? And so if your serotonin transporter doesn't work, then giving you a drug that will make it not work doesn't really seem to be a good idea. And so what they'll do is they'll look at these genetic variations, and they can, your doctor can figure out like, oh, your serotonin transporter is screwed up anyway. Let's skip the SSRIs and try something else. So you're not taking a drug that's not going to work for you. So that's pretty cool, right? So there you go. Everybody go get, gene paneled. What about the Nocebo Effect? Who's heard of that one? Yeah, the Nocebo Effect's pretty cool, right? It's sort of the opposite of this. If you expect bad things to happen, guess what? They will. And this is particularly true for side effects, right? If you read all of the side effects, I don't know, I'm assuming most of you have taken a medication with a side effect list, right? If you read all those side effects, guess what happens? You increase the likelihood you're going to have those side effects. The problem is we should probably let you know there are side effects, right? So you don't like take a drug and all of a sudden like, I don't know why my ear fell off. That's a problem. So we really want to make sure we let you have those, but that can increase. You're thinking about the negative expectations, you're thinking about the anxiety associated with that. That can really influence that sort of treatment. So the nocebo effect is something to think about as well.
The biggest problem with the side effect list is that they have to report anything to the FDA that happens to their trial during treatment.
Yeah.
So somebody could have another condition that makes them already have high blood pressure, and if they report higher blood pressure, like randomly during the experience, then maybe they didn't take their lisinopril that day. So then they have to report to the FDA that this drug can cause high blood pressure, even though it actually doesn't.
Right. You're absolutely right. The approach that we have taken with that as a society is it's better to be overly cautious with drugs than it is to not. And the reason for that is there are some really there's some drugs out there that can cause you some bad problems for you, or for those of you that at some point might decide to grow another person inside of you, which is going to be an important thing we'll talk about at some point, right? We'll talk about the placental barrier and so forth, and birth defects and developmental issues. So it's one of those things like, should we tell people that it can cause high blood pressure because maybe one guy sort of had high blood pressure, or should we just skip over that? Well, with the high blood pressure thing, that's a pretty innocuous example, but what if somebody develops some rare liver disease, and then you're like, that was actually a bad thing, maybe we should have told people. So it's like a catch-22 almost, right? You don't want to know the side effects because you want your drug to work, but at the same time you want to know the side effects so that if you do notice something weird happening, you can discontinue taking the drug, right? And so
they do publish data now on the incidence of side effects too, so you can look it up. There's like a couple of websites online you can look up whatever drugs you're taking, and it'll say like in ranking, it'll say like this happened to 30% or more people, this happened to like 10% or more, this happened to like 5%, this happened to like less than 1% or something.
Yeah.
So you can see how likely it is that you'll develop like Stevens-Johnson syndrome versus like
diarrhea.
A cold.
Yeah, they're all diarrhea. Like it's always like every drug you take, it's like constipation or diarrhea. I was like, how do you get both? I'm not really sure how that's working. They list them both. It's like, well, all right. Yeah, you're absolutely right. So I think being an informed consumer of drugs is an important thing to do. And I think for me, and in this class, I'm never going to tell you not to take drugs, either medicinally or recreationally. But I will tell you, it's better to know what you're getting into, right? And so that's my general take on things. If people are going to do something, we should try to make it safe for them, right? As safe as we possibly can, because bad things can happen. And we should really, we should really provide support for individuals, right? I'm not saying like let's go around and shoot people with heroin. Sounds like a bad idea. It's a horrible idea. It's a horrible idea. But if somebody's using heroin, let's do things so that they're safe, so we can get them to not use heroin, right? Instead of just letting them die. I think that's probably a better approach. That's my take on it. I'm not going to, in general, give you too many opinions in this class. Everything I say is an absolute fact, and it's perfect. But that's one time where I think, are people going to use heroin? Absolutely. How long have people been using heroin? Since heroin was, right? People have been using and abusing drugs, as we figured out, since before we were a species, right? So let's see what we can do to try to help people through that. And figure out what's going on. All right. Nocebo effect. Often they'll use placebos to evaluate the effectiveness of a medication. This is why it is difficult, one of the reasons why it's difficult to get drugs to market, especially antidepressants, for example, right? Most antidepressants don't work that much better than a placebo, and often they'll use placebos as a pill. Sometimes they'll use a placebo just to make you go talk to somebody, right? If you can just go sit down and talk to somebody for an hour a week, and you feel just as well as you do if you were taking, I don't know, what's a good antidepressant that's out? Zoloft, right? Then why would you take Zoloft? Sitting for an hour and talking to somebody is probably not going to make you, it might make you sleepy, depends on who you're talking to, but it's probably not going to cause weight gain, it's probably not going to cause sexual dysfunction, it's probably not going to cause a bunch of the other side effects that you might have if you were taking something like Zoloft, right? So we're not going to want to say, yeah, this is a great drug. We want to say this is a drug that's so much better than you just sitting down and having a chat with somebody, or you just thinking you can get better, or you just and I don't mean this in a callous way, just toughen it out for 3 weeks, right? Until you feel better. Most everybody will be depressed at some point in their life. If it's not happened to you yet, hang in there, it's coming. I'm just gonna throw that out there. Most of the time it doesn't last very long, right? Now it can seem like it's very long even if it's just a few weeks, right? Most people who are depressed, it's a short-term thing and you get through that. Some people it's not, right? And so you got to do something different, right? Being depressed is a perfectly normal thing. You lose a family member, they pass away. You should probably be depressed for a little bit, right? If you're not, we're going to worry about you. But it's when you don't pop out of that after an appropriate amount of time, right? And so that's the thing. So we want to make sure the drug we're giving you is actually going to give you more benefit than harm versus, you just approaching things that don't have negative side effects, right? Going upstairs to the clinic, if you need that, I want to mention, I always try to plug the clinic upstairs. It's free, right? You can go up and you can talk to like actual people who know what they're doing to make you feel better for free as a student, so that's an awesome thing. So feel free to head up there. They'll also do things like you're anxious about class, you're worried about like what kind of major, what to do with the rest of your life. They'll help you up there with that too. They'll get you to the right resources if they can't help you right away. They don't handle crisis things, I don't think. I think you have to go over to the counseling center if it's a crisis situation, but if it's just kind of a long-term thing, you're like, hey, I'm anxious a lot, I'm depressed a lot. You're not in the middle of some immediate crisis, you can go there and they'll set you up with appointments if they have the staffing to take you on. But we don't want to, there's no side effect to that, right? There's no side effect to going up and talking to somebody that we have up in the clinic, right? It's not going to cause you these negative reactions. You're not going to go up there and have some anaphylactic response to that, right? You're not going to swell up all of a sudden and your tongue balloons and you can't breathe. That could happen if you take Zoloft, right? We don't know until you take it. So I guess give it a try. If you can't breathe right after you take it, stop. That's a recommendation. All right. We do want double-blind experiments. We will talk quite a bit about methods. We'll talk about this more later. It's really great because we've already kind of outlined, like, you thinking about your drug experience can influence what happens. The way someone treats you, like in that interaction while they're giving you the drug, can also influence that experience, right? So we want people who are double blind, right? So we want people who you don't know if you're getting the drug or the placebo, and I don't know if I'm giving you the drug or the placebo. Now, someone has to know, right? Or we're just like randomly giving people stuff and we're like, well, some people got better, but we don't know who had the drug and who didn't. Someone has to know, but not the person who's actually like administering that, right? So that's going to be double blind. All right. Often folks will use the word bioavailability, right? How many of you have heard that word? That's a common word out there, right? It's just like how much drug is in the blood that can actually bind to a target site. That's bioavailability, right? How much do you have of that available, right? How much of it is not bound to something? We'll talk about where this can bind, okay? We're going to spend some time now talking about related issues with pharmacokinetics, right? And these are a bunch of factors that will influence that bioavailability. So there are sort of 5 things that we want to consider here when you're taking a drug, right? Route of administration. How are you getting this drug into your body? How many of you have taken a drug that has more than one route of entry into your body? Like most people have, right? Caffeine's caffeine's not a bad. I guess you could inject caffeine. I don't know that you would want to. Are you going to make that face all semester, Natalie? Like,
My face.
I know, but you're so like.
The only professor that does that to me.
You're like.
All day long.
And you've been in my class before, so you know.
You said it to me then.
I know. You shouldn't be surprised.
Real bad or bad.
Okay. We'll figure out a treatment for that.
Okay.
So let's think about, like, cocaine's a great example. For our purposes, I'm going to assume none of you have used cocaine. And if you have, you don't have to share that. This is recorded, so keep that in mind. I won't record your presentations. I'll only record what Montana or I do. Okay? So I just want to be clear about that. When I don't think I mentioned that. So but that was important. Because you may share something personal during that time that you don't want recorded. So there you go. Cocaine. What are the ways you can take cocaine? Well, it's injectable, right? You can inhale it. You can snort it, which is different than inhaling. We'll talk about that. So there are different ways you can take cocaine. They have different sort of action times. That's why you take things in different ways, right? They they have a different onset of that experience, okay? When you're thinking about drugs of abuse, you typically will see people use those and administer those in the way that has the most rapid onset, right? You don't want to take cocaine and then 6 hours later it kick in, right? It's like, oh, you know what I'm thinking about this afternoon? Thinking about a cocaine high, so I probably better do this when I'm eating my brunch. And then, you know, about 3 o'clock, I'll get a little afternoon boost. That's not how it works, right? When you're thinking about drugs that you take to treat medical conditions, though, there are times when you want a slower release. There are times when you want drugs to take a little bit of time to get somewhere, right? And so that route of administration might be important. We're going to absorb drugs and distribute that. Distribution is all going to happen through the blood. I mean, that's pretty well the way it goes. Absorption is important. We're going to talk a lot about lipid solubility at some point in the future. You have to get the drug into cells, right? That's where the target sites are. You got to get that in. You have to get it through barriers sometimes. There are two important barriers. One, we already mentioned, the placental barrier. For our purposes, probably a more important barrier is what we call the blood-brain barrier, right? There is a barrier between your brain and your blood supply, and that's to prevent toxic substances from getting into your brain and causing it problems, right? And so your capillaries, those blood vessels in your brain, have a certain structure to them that don't allow molecules to pass through. There are some big exceptions to that. One of those exceptions is drugs that are lipid soluble, right? Your cells are made out of lipids, right? You guys know the phospholipid bilayer from, like, you know, sophomore high school biology, right? Well, we're coming back to it. I know it's a long time ago, Brooke, right? It was a century ago for some of us. Yeah, I think quite literally. That was like last century when I took sophomore high school biology, like 1999. So you can get through there. If you want a drug, Kaylee, to work on your brain, you better figure out a way to get it past that blood-brain barrier, right? So you better make it very lipid soluble. So any drug that you take, any antidepressant you take, any anti-anxiety medication you take, any drug that you take that is going to alter your sort of mental state is going to pass the blood-brain barrier. It's lipid soluble, right? One of the most lipid soluble drugs out there is alcohol. Right? Alcohol very quickly gets through the blood-brain barrier, and it does amazing things to you, right? It makes you much more athletic because you can always jump over so much more, right, after you've had a little bit of alcohol than you could before. Like, everyone turns into a pole vaulter. I've seen it. And then you see the bruises the next day. So that's how we have to get absorbed and distribute. While we're distributing, we're looking for that binding site, wherever that is, right? I mean, if it's a drug we're thinking about in your brain, all those binding sites are going to be on brain cells, right? So they're going to be located there. If this is something that's going to affect cardiac function, it's going to affect the way your kidneys work, there are binding sites in those organs, right? Now, how many of you have, we'll actually have you raise your hand. How many of you have ever taken a drug? We'll just all raise our hands, right? You've probably taken Advil. That's a drug, right? That's caffeine. We know some of you are taking caffeine. When you take Advil, how many of you have taken Advil? Anybody want to own up to that? All right, Emily, I'll use you as an example, right? How often do you have to take Advil?
We take it for 6 hours.
Right. Why is that? It doesn't work all the time,
Yeah.
right? You inactivate that drug. You break it down, right, into something that's not Advil. And so it no longer has that desired effect, and then you excrete it. Anybody know the number one place where you excrete drugs? Yeah, right? That's why, what's the number one way they test for drugs? Urine. Yeah, urine test, right? They're not like, hey, let me rub your ear and see if some drug molecules fall off. It's not where drugs come out. Drugs come out in your urine, right? And so they'll test your urine. There are a few other places where drugs will come out. One of those is in your breath. Right, if you're ever pulled over by the police. Hair follicles is another one, right? And so they can test those. This actually brings up a bit of a problem with drug screening, right? And this is starting to become a bigger problem as some states are legalizing certain drugs and other states are not. right? And so we're in a perfect example where you could live in one state, because we live in a place where you can get to a couple other states pretty quickly, right? And you could imagine a situation where, let's say, Ohio, for example, has legalized recreational marijuana. You live in Ohio, you got some friends in Ohio, you just drive over the river, right, for that particular purpose. You're doing something very legal, right? And then marijuana in particular is a troubling drug to test for because of the way it deposits in your body. And we can talk about what we call depot binding in a bit. It'll actually bind to your bone and fat cells and then can come out at a later time. So you may have gone over there last weekend, right? And you may have used some recreational marijuana. You come back to work, you are no longer feeling the effects, right, or impaired maybe from that. But you may still test positive for that if you had a random drug test at work or something, right? So you can kind of see where there are some issues that can be created with that. So just try to give you that information so that you can navigate those as appropriate, right? And you think about that. It's really kind of interesting. That's a thing. What was it, a few years ago? The NFL removed marijuana from their banned substances list. You guys remember when that happened? And that was because there were certain states that were legalizing marijuana. They didn't, if you test an athlete for a drug that's legal, he can simply say, well, I was in a state where that was legal when I did it, and then enforcing that policy becomes impossible, right? Especially for an individual who travels a lot, right? I mean, let's say this is an individual who happened to play the Broncos last weekend. And then they test positive for marijuana, but they're in, I don't know, they're in a much more, I don't know, I'm trying to think of a state where they, they're in Charlotte, North Carolina, right, where maybe that's, I don't know if it's legal in North Carolina, I can't imagine it would be. I lived in North Carolina for a while, that's why I can't imagine it would be. They only had 3 things where we lived there. They had Krispy Kreme and BB&T, which were both based in the city I lived in, and churches. So that's why I feel like it wasn't that likely. So then let's say you play for the Carolina Panthers and you test positive. You're like, oh, well, we were playing the Broncos last weekend. I had a little downtime. It was perfectly legal. So you can see these enforcement issues that kind of are created with that. I really wasn't necessarily related to all this, but I thought it was important to share. Questions about that? Anything else? Great. This is actually a pretty nice diagram, right? It kind of runs you through the process of all of these pharmacokinetic factors, right? So you're going to, we'll just kind of talk about each of these in detail so you can have some idea about what's going on, right? Effects of drugs, how rapidly the drug gets to its target. If you've used the drug before and how often you've used the drug, we'll talk about tolerance mechanisms at some point in the future. Right? I just want to briefly mention that. There are different ways that you can develop tolerance. Some of that is enzyme induction, right? This happens, for example, with alcohol use, right? As you continue to use alcohol, if you do that at the right rate and at the right amount, you'll actually start to create more of the enzyme that breaks down alcohol, right? That's one of the reasons that tolerance kind of goes up. Okay. There are basically 2 broad ways that you can take drugs. You can either get it into your GI tract. A couple ways you can get it in there. There's the top floor and the bottom floor are kind of the two ways in, right? Okay. Some of you definitely know which the one way in. The other one you usually think of it as a way out. But rectal administration is, for many cases, a great way to take a drug. And then sort of anything else is a different way. So let's kind of run through some of these ways that you might take them and why some are preferred over others. Oral administration is typically the preferred method if possible. The reason is it's easy to do. Most people can take pills. It's relatively safe, right? You're not concerned with like with an infection from needles, accidental needle sticks, things like that. There are some drugs that you can't take orally. Insulin's a great example, right, to treat diabetes. Insulin's destroyed by stomach acid. So if you take a pill for insulin and then it is destroyed in your stomach, I don't think that really helps your diabetes any, right? Because the insulin was destroyed. It's kind of a waste of time. There are some drugs, we talked about that blood-brain barrier, that don't cross the blood, that don't cross that. So think about like antibiotics, for example. If you had a brain infection, we may need to crack your head open and put that antibiotic directly into your brain, okay, so that we could treat that. And that's so we can bypass those. Okay. Sorry, that's a lot of flipping around. Things that can affect oral administration. Obviously, food. There are some drugs you should take with food, some drugs you shouldn't take with food, right? Read the label, right? There's a reason for that. Not all drugs are affected the same by foods, right? So a great example is there's actually a relatively new like antacid medication that just came out. It's a proton pump inhibitor. It's the first proton pump inhibitor that you can take with or without food. Previously, you always had to take your proton pump inhibitors, your Nexium, for example, right? Like half an hour before you eat. This guy, you don't have to, right? Because the food that's in your stomach doesn't affect the absorption of the drug. Other drugs were affected by food, and so I don't know if any of you know someone who's like got bad acid reflux. They're constantly kind of like, oh, well, I want to eat now, but I haven't taken my pill, so I got to take my pill, and then we got to wait an hour, right? And so then you're just like killing time at the Gap or something until you can eat. I don't know, right? It's life of people with acid reflux. I saw it on a commercial. Do we want to talk about first pass metabolism a bit? The idea here is that if you take things orally, they don't immediately jump out into the rest of your body. Your liver's got a funky little trick where it can kind of get its hands on this stuff and break it down if it's something toxic to you, right? All right. This is a nice diagram showing you different routes of administration. I still want to talk about some of these in detail. We talked about rectal administration. Avoids that first pass metabolism, right? Because it's not going through the liver before it gets absorbed from your intestine. Also great if you're vomiting, right? They'll often give you anti-nausea medications this way. What's a bad idea is to take an anti-nausea medication and then vomit that medication up, right? Again, it's not helpful, right? So if you put it in the other way, it's not going to come out as fast, and you can absorb that medication. What about IV? IV is a great way to take drugs. Very quick onset, right? You get it into the blood supply immediately. You can get that circulating going where it needs to. Problem with an IV injection is if you made a mistake, I'm sorry. There's no way to fix it, right? It hits you so fast that you can't really make adjustments, right? If you take a pill and you have some kind of reaction to that, you can get your stomach pumped or something, right? And you can kind of work on that. But with IVs, you can't do that. You also have sort of secondary issues with infectious diseases from using needles. It's particularly important for drug abuse, but it's also in cases where maybe the hospital or the administrating healthcare professional did not use good, sterile techniques, right? And this happens from time to time. Okay. What about intramuscular injections, right? How many of you have had one of these? It's a shot in the shoulder, shot in the butt, usually where you get these, right? A bit slower, so you can absorb things over time. Often they'll kind of mix it with some vegetable oil, so it'll slow that down even more, right? So slow that absorption. I think flu shots, anybody get a flu shot? Usually that's an intramuscular injection, right? The reason these hurt, I don't know if you've had an intramuscular injection and they hurt a little bit, aside from the needle stick, right, is that the pH of the drug that they're putting in you is different than your internal pH, right? And it can cause some pain that way. Intraperitoneal, honestly, don't worry about this too much. Rarely is it used with humans. but occasionally, we would use this in a laboratory situation. You just inject the drug right through the abdominal wall into that abdominal space, right, for absorption there. Again, much more common in lab animals than humans, so not really something to think about.
Is the rabies vaccine, is that still IP for humans?
If it's like an after the fact situation, yeah. If you're getting it as a preventative, they'll give it to you in the shoulder 3 times. That's how often they'll give that to you, in case you want to know. And then they'll test your blood antibodies to make sure you've got enough to fight off rabies. So if any of you are rabid and you try to bite me, I'm safe. That's the moral of this story, because I had the rabies vaccine. Although it may have diminished a little bit. I wouldn't have to, like, after the fact, like, let's say you didn't get a rabies vaccine and you get attacked by, like, a rabid fox or whatever, you probably have to have, like, 5 shots maybe. If you've had the preventative vaccine, maybe 1 or 2, right? So you can kind of reduce that a little bit. Not a pleasant vaccine to get unless you need it, because it actually was quite painful. Yeah. I thought I was going to handle a bunch of ferrets once that might have rabies, and so it was a long story. So when I was in North Carolina, they were really worried about rabies down there. It's like constantly, like, you're hearing stuff, like on the news, like 5 stories about rabid raccoons. And
Is it because it's so swampy?
I don't know.
I think it's just because it was a small town. Because I come from a really small town, and like every other day they're like, "Does your dog have rabies?" Maybe.
Yeah, they're just worried about it. I don't know. It's like, don't go out in the woods. A bat will get you. Actually, it's mostly bats. Actually, I mean, I don't know how many people get attacked by bats. I guess it happens. I mean, but you can get rabies from bats. I think they're the number
That's
one.
actually what happened to the first girl that like recovered from rabies, like at the hospital. She was at church and there was a bat and she like grabbed it and bit her.
That doesn't seem like a smart idea.
I mean, no.
Yeah, no,
At
there
least
you
she
go.
got to learn from it.
Hey, there you go. That's worthwhile, right? We also have subcutaneous injections. It goes just under the skin, right? Typically, we would think about something here that would be like an implant or like some small pellet. I think they do some birth control this way, right? They'll kind of like put it under the skin, and they're good for, I don't know how long. You just give it a try, see how long it works.
Depo is like 3 months.
Yeah, right. Which is better than like I forgot to take that pill that I take every day, which apparently happens, and then you can kind of run into some issues. Especially when you're dealing with hormones, you want that, like, a steady release is actually kind of a better idea. I mean, especially if you are forgetful or your schedule's not like steady. What about inhalation, right? This is when you absorb things through the lungs. We typically think about this for things that you would smoke, like nicotine, marijuana, something like that. But also there are other drugs that are given, especially if you have some sort of bronchial constriction issue, right? They could give that to you. You could inhale that. Inhaling is different than snorting, just to let you know. Even though you think it's going in the same place, it's not. Snorting is it's actually we'd consider that more of like a topical administration, because you're going to a mucous membrane, right? And so you're gonna get that through the mucous membrane. Intranasal is much faster than just like rubbing something on your skin, right? Because it can get into the blood supply faster and into your brain. Sublingual, that's kind of interesting. Some folks will put things under their tongue. There are those medications that'll dissolve under your tongue. I mean, that's kind of an interesting approach. Other intranasal things, you can give people oxytocin to treat autism. It's sort of an interesting approach on that. Snorting, let's skip that. I mean, we just talked about it. Transdermal, that's skin patches, right? Used for a lot of things. If you have motion sickness, you probably have a little dot of something behind your ear. You can use it for hormone release as well. They'll sometimes use this with vaccinations if they're doing like for an outbreak. The reason it's often used for vaccinations in that case, if you really just want to like slap people on the arm with like a vaccination patch and send them on their way. If you've got a lot of people to vaccinate, and you're worried about accidental needle sticks. What about epidural? This is when we'll stick something right into the spinal cord. I know. Now, Natalie, that was a face you made. that was a clear face. So what they'll do is kind of find a gap between your vertebra and jab you with it, and then you don't feel anything for a while. So we already talked about sticking stuff in your brain directly. There are infusion pumps, right? So these are things you put under your skin, and they deliver different drugs over time. They put gene therapy here as like a gene therapy is kind of an interesting approach to treat certain disorders. It involves giving people a virus, which sounds horrible, but it's not. A virus is really great at doing two things. All viruses are really great at getting into your cells, and then they're really great at tricking your cell into making their own DNA. Now, if that DNA gives you something like cholera, well, that's not so cool, right? But if that DNA gives you something exciting and helpful, then you're good. There's actually gene therapy treatments they're working on now to treat color blindness, which is kind of interesting. So if you're colorblind, they can use gene therapy to give you the to get your rods or your cones rather to make those appropriate molecules, which is kind of exciting. What's important with route of administration is how quickly and how high is the concentration of the drug in your blood supply, right? And so this is an example. I believe this is for cocaine. And so what they've done is they've given someone or show you the different sort of time courses of concentration of the drug in the blood. IVs obviously like immediate and super fast. Other drugs take a little bit longer, right? And so that's really what you want to sort of take away from that. Here's a nice chart. Gives you sort of advantages and disadvantages of these drugs so that you can, or drug routes of administration, so you can think about that. When we're thinking about psychoactive drugs, right, which is what we're going to think about in this class, that absorption piece becomes really important, right? Because again, we're concerned about that blood-brain barrier and getting through that phospholipid bilayer. So what I'd like to do is stop here for the day. We're almost out of time. Lipid solubility and